Welcome to another Journal Club session. This presentation was co-created with Kay Fasulu, one of the Master of Nursing and Child Nursing students, and presented by myself, Ilana Weber. This month's article is titled Bronchiectasis in African Children, Challenges and Barriers to Care. It was written by Verwey et al. And published in the journal Frontiers in 2022. Let's dive in. Bronchiectasis is a chronic lung condition marked by abnormal dilatation of airways due to repeated infection and inflammation. In Africa, despite an increased awareness of childhood bronchiectasis, data on childhood bronchiectasis are scarce, even though there is high exposure to infectious diseases that predispose children to bronchiectasis more than in high-income settings. Most diagnostic investigations, such as computed tomography or CT scans, and management strategies are extrapolated from high-income countries or cystic fibrosis literature, which may not reflect African setting realities. This study therefore aimed to highlight the risk factors, diagnostic challenges, and barriers to care for African children. This was a review article where the authors synthesized existing literature in the form of published studies, guidelines, and expert opinions on bronchiectasis in Africa. The authors started by looking at the burden of pediatric bronchiectasis. Bronchiectasis was previously considered an uncommon or orphan disease, but increased use of chest CT scans has shown that it is more common than previously believed. High rates of pediatric bronchiectasis have been reported in socioeconomically disadvantaged populations in high-income countries. However, it is not limited to these populations and occurs more broadly. Risk factors for pediatric bronchiectasis in high-income settings include recurrent lower respiratory tract infections, pulmonary tuberculosis, differences in the airway microbiome, genetic susceptibility, low socioeconomic status, and limited access to health care. But what do we know about bronchiectasis in Africa? Well, not a lot. Existing studies suggest that a significant proportion of children attending respiratory and HIV clinics have bronchiectasis. Let's look at the factors that contribute to increased bronchiectasis risk in Africa. High burden of recurrent and severe lower respiratory tract infections, including tuberculosis, high prevalence of pediatric HIV infection, particularly in sub-Saharan Africa, lower childhood vaccination coverage against key respiratory pathogens, lower socioeconomic status, poor access to healthcare services and long-term follow-up, and lastly, limited awareness and knowledge among caregivers and healthcare providers regarding chronic wet cough, persistent bacterial bronchitis, and early identification and management of respiratory disease. This is the area where nurses can play a big part in the identification and management of childhood bronchiectasis. As with most pathology, in order to diagnose and manage it well, you need to have a good foundational knowledge of what it is and how it affects the child. Bronchiectasis results from a vicious cycle of infection, inflammation, and impaired mucociliary clearance. Repeated respiratory infections damage airway epithelium, leading to permanent bronchial dilatation. Chronic inflammation promotes mucus hypersecretion and bacterial colonization, thus perpetuating further injury. The causes of bronchiectasis in African children are largely unknown due to lack in specialized diagnostic tools, which means that a large proportion of children will still fall under the post-infectious and idiopathic group. Post-infectious include severe or recurrent pneumonia, tuberculosis, and pertussis. More research is required to understand the true etiology in the African population. Let's look at the diagnosis of bronchiectasis. Current guidelines recommend that diagnosing pediatric bronchiectasis should be based on a consistent clinical syndrome as well as confirmed airway dilatation on chest CT scan. In many African settings, access to CT scans are limited or restricted to specialized centers. This lack of CT availability contributes to under-recognition of bronchiectasis, delayed diagnosis and treatment, poorer long-term outcomes, as well as reduced public awareness and healthcare funding for bronchiectasis. Chest radiography is often the only available imaging modality. Whilst chest X-ray may miss milder bronchiectasis, specific radiographic changes usually indicate severe disease. The authors propose that in resource-limited settings, diagnosis and initiation of treatment may need to rely on clinical features and chest radiograph findings. Many of the international guidelines recommend for the diagnostic workup of bronchiectasis is based on data from high-income countries that may not reflect the causes of bronchiectasis commonly seen in Africa, and financially unrealistic for many African healthcare systems. The guidelines acknowledge the need for HIV testing and tuberculosis screening in regions where these diseases are endemic, as it enables earlier diagnosis and treatment, as well as reduced HIV disease burden. Children with lower respiratory tract infections are commonly screened for TB. These practices may contribute to reducing the bronchiectasis burden, although further research is needed. For the full proposed diagnostic and investigative algorithm, see Figure 1. Management of bronchiectasis focuses on treating the underlying cause, managing symptoms and complications, and finally preventing further lung damage. Lung protective strategies include prompt and aggressive treatment of lower respiratory tract infections and exacerbations, ensuring immunizations against common respiratory pathogens, as well as avoidance of environmental exposures that damage the lungs, such as tobacco and indoor biomass fuel smoke. Management should be adapted to the underlying disease and available healthcare resources. Airway clearance and treatment of infections are the foundation of bronchiectasis management. Airway clearance techniques include positioning and chest percussion, active cycle breathing techniques, and mechanical airway clearance devices. Manual airway clearance techniques should be taught to healthcare providers, children, and caregivers, as they are low cost, widely accessible, easy to learn, and particularly important in low resource settings. Infection should be appropriately treated with affordable antibiotics that can reduce the frequency of lower respiratory tract infections, the severity of the infections, as well as the risk of post-infectious bronchiectasis. Early recognition is vital for timely treatment to be provided and an opportunity to prevent progression to established bronchiectasis. It includes key interventions such as recognizing chronic wet cough early, appropriate antibiotic treatment, and regular follow-up of symptomatic children. Bronchiectasis can't be properly managed if you don't address the broader social determinants of health. Less poverty and improved access to healthcare can lower the burden of respiratory infections, promote earlier diagnosis of bronchiectasis, and facilitate referral to specialist centers. Improved healthcare education in turn can support earlier recognition and management of at-risk children. There is a need for specialist services and advocacy in the management of bronchiectasis as well. There are many advanced treatments for specific causes of bronchiectasis, such as cystic fibrosis and primary immune deficiency, but these remain inaccessible in much of Africa. However, treatment options for common causes of bronchiectasis are available and should be strengthened. The authors advocate for regional and national centers of excellence, greater research into causes and outcomes of bronchiectasis in Africa, as well as efforts to reduce inequalities in child health. See Table 1 for the full management of bronchiectasis in Africa. Long-term outcomes in children with bronchiectasis depend on the underlying cause of the disease and the severity of lung damage at diagnosis. Children with non-cystic fibrosis bronchiectasis generally have poorer lung function than children with cystic fibrosis-related bronchiectasis. Early initiation of highly active antiretroviral therapy in children living with HIV has been associated with improved lung function during the first 2 years of treatment. The relationship between nutrition, bronchiectasis, and long-term lung function requires further investigation. The authors have the following recommendations as essential steps toward reducing preventable morbidity. They suggest an alternative definition focused on prevention and clinical management. For investigation and treatment, They recommend that all children with suspected bronchiectasis must be investigated, started on a pulmonary rehabilitation program with regular follow-up 3 to 6 monthly, and that parents should be educated about minimizing harmful environmental exposures. African research capacity should be strengthened to build local evidence vital for context-specific guidelines. National and regional bronchiectasis registries should be established to enable systematic data collection on prevalence, risk factors, and outcomes as registries support policy development, resource allocation, and research prioritization. Advocacy should focus on raising awareness among healthcare workers, policymakers, and communities. Promoting early recognition, improving access to diagnostics, and integrating bronchiectasis management into child health programs are essential steps toward reducing preventable morbidity. In conclusion, bronchiectasis remains largely under-recognized and underappreciated in Africa. Simple, practical diagnostic algorithms could help healthcare workers to identify children at risk earlier, initiate treatment sooner, prevent disease progression, as well as reduce the severity of established disease. Strengthening research capacity across Africa is essential to address research gaps that can guide clinical decision-making, inform treatment guidelines relevant to African contexts, support advocacy for increased healthcare resources, and influence policy development and funding priorities. We have come to the end of the presentation, and now it's time to reflect on your own practice. You can pause the video here and go through each of the questions. Or can you maybe think of other questions particular to your context? Thank you for your attention and look out for our next Journal Club session.